Hello everyone and welcome. I'm absolutely thrilled to have you here for today's explainer. We're going to be intensely focusing on the clinical approach to demyelinating disorders. Specifically, we're honing in on MOGAD. That's myelin oligodendrocyte glycoprotein antibody-associated disease, and ADEM, acute disseminated encephalomyelitis. We're going to decode these incredibly complex conditions using the absolute latest evidence-based guidelines, building a clear, actionable pathway from your very first clinical suspicion all the way to a confirmed diagnosis. So if you're looking to really sharpen your diagnostic precision, you are in the exact right place. Let's get started.
Okay, let's dive into this. Here's our clinical roadmap for today. Decoding MOGAD and ADEM, when to suspect MOGAD, core clinical presentations, diagnostic requirements and caveats, essential investigations and imaging, and finally, our final takeaways.
Section 1. Decoding MOGAD and ADEM, Foundational Concepts.
So at the microscopic level, we're looking at the underlying damage to the myelin sheath and the neurons themselves. Think of myelin as the rubber insulation on a really important electrical wire. When that insulation is stripped away by autoantibodies, the neurological signals literally short-circuit. This structural breakdown, this demyelination, is the very engine driving the complex and honestly sometimes confounding neurological symptoms we're about to decode. Keeping this mental image of cellular damage front and center makes it so much easier to understand exactly why these diseases present the way they do.
Moving on to Section 2, When to Suspect MOGAD, Triggering Suspicion.
Now, the most important thing to understand here is that MOGAD is a bit of a clinical chameleon, right? It doesn't just present in one single uniform way. Instead, the evidence tells us there are 4 distinct, highly specific initial clinical presentations. When a patient walks through your door exhibiting one of these 4 presentations, well, that's exactly when the alarm bells for MOGAD should start ringing loud and clear.
Which brings us to Section 3, Core Presentations, Clinical Manifestations. Now, what's really interesting about this first presentation, optic neuritis, is the required specificity. We aren't talking about just any run-of-the-mill optic neuritis here. To actually raise suspicion for MOGAD, it must be simultaneously bilateral. It has to involve the anterior optic pathway. And, crucially, it must be associated with optic disc edema. This level of precision is absolutely key to separating MOGAD from other demyelinating diseases, like MS, for example, which historically were just kind of lumped together before we had these exact clinical distinctions.
The second presentation to watch out for involves acute disseminated encephalomyelitis, or ADEM, and ADEM-like presentations. But listen, clinical symptoms alone just aren't enough. They have to be accompanied by specific imaging hallmarks. You're looking for large, poorly demarcated T2 hyperintense lesions in the brain. Basically, they look almost like blurry, washed-out clouds on the scan rather than sharp, distinct dots. And these must be paired with T2 lesions within the spinal cord. Finding both of these gives us a much stronger diagnostic foothold.
The third trigger for suspicion is unilateral cortical encephalitis. This presentation involves a very distinct constellation of acute neurological findings. Patients will often present rapidly with a headache, fever, seizures, or a broader encephalopathy. But again, you absolutely must pair this clinical picture with the imaging. You need to look for cortical T2 hyperintensity and focal cortical swelling. The sheer speed at which these symptoms can onset is often what brings the patient rushing into the emergency room in the first place.
And our fourth core presentation is a complete spinal cord syndrome. Now here's where it gets a little tricky, distinguishing this from a partial syndrome. So the crucial point is that a partial syndrome might not immediately point to MOGAD, but a complete spinal cord syndrome, especially when it's accompanied by prominent bowel, bladder, or erectile dysfunction symptoms, well, that should immediately elevate MOGAD on your differential diagnosis list. It's a striking clinical difference that completely changes your diagnostic trajectory.
Let's move to Section 4, Diagnostic Requirements and Caveats, Rules and Pitfalls.
If you remember only one single thing from this entire explainer, let it be this. Anti-myelin oligodendrocyte glycoprotein immunoglobulin G, or MOG-IgG, is absolutely required for the diagnosis of MOGAD. This isn't just a suggestion, it is the absolute golden rule. Without this positive test, you simply cannot definitively make the diagnosis. Period. However, there is a massive caveat that we really must address. While a broader spectrum of clinical features might sometimes be seen, extreme caution is needed if you're testing patients who do not have those 4 core manifestations we just outlined. Why? Because the potential for false positives is highly significant, particularly at lower titers, where background immune noise can basically trick the assay.
Ordering tests without the appropriate clinical context will absolutely lead you down the wrong path.
Furthermore, you must always keep your red flag filter active. If you encounter clinical, laboratory, or MRI features that fall outside the typical MOGAD presentation, these are major red flags. They strongly raise the likelihood that you're actually dealing with an alternative diagnosis and you need to pivot your investigation immediately.
Section 5, Essential Investigations and Imaging. Workup Protocols.
Systematically, your initial imaging evaluation must include an MRI, both with and without contrast, of any symptomatic region of the neuraxis. But here is where the protocol logically expands. If there is any diagnostic uncertainty whatsoever, or if encephalopathy is confounding your neurological examination, you must add all of the following scans to your order: an MRI of the orbits with fat saturation images, an MRI of the brain, and an MRI of the spinal cord. You have to capture the full picture to be sure.
Let's move to the fluid analysis and see how this builds into our laboratory workup. For serum, you must test for MOG-IgG, and it's vital that this is done using a cell-based assay for actual accuracy. Alongside this, a cerebrospinal fluid, or CSF, analysis is totally required. This should include your routine studies, things like cell count and differential, as well as testing for oligoclonal bands.
Now, the guidelines also specify testing that is reserved for select patients. These aren't for everyone across the board. In certain clinical scenarios, you'll want to add PCR testing for viral infections. Additionally, in select patients who present with specific confounding features, specifically things like orofacial dyskinesias, psychosis, or seizures, you must test the CSF for NMDA receptor antibodies to rule that out, because anti-NMDA receptor encephalitis can beautifully, and quite dangerously, mimic these exact demylinating symptoms.
Section 6. Final takeaways. Clinical pathway.
As we wrap up, I want to leave you with this provocative thought. How do these strict criteria, the required core presentations, and the severe caveats regarding false positives fundamentally reshape how we approach demyelinating diseases? It really highlights the evolving, incredibly precise nature of neurological diagnosis today. We can no longer rely on broad assumptions. We have to lean on exact, evidence-based clinical algorithms to ensure our patients get the right diagnosis and the absolute best care.
This comprehensive look at the evaluation and investigation of MOGAD and ADEM was prepared and presented by Dr. Sarah Altayeb Omer Altayeb. Thank you so much for joining me for this explainer. I really hope this structured, evidence-based pathway empowers you in your clinical practice and helps you navigate these complex demyelinating disorders with total confidence and precision. Keep learning, keep questioning, and I'll see you next time.